I have the privilege to moderate this next session. And I was actually watching a video cast of Arvind Krishna, who's the CEO of IBM. And he's been there 30 years, and he was asked, what have you learned whilst being at IBM? And he said two things. One, I'm always learning. So I'm here to learn from these individuals. And two, I'm actually always a little nervous when I get up on a panel. And that's because I really respect my audience, because they probably know more than me. So I'm a little nervous, and I don't know if the rest of my panel are nervous, but with the audience here, hopefully we'll have a great discussion. So we're going to be talking about innovation, about policy, about prevention. We've got a great panel here. So I'm going to hand off. We'll just go in order. Start with Abby. And if you could just introduce yourself and say a little bit about what you do.
Can everyone stand up for a sec? We're the last panel of the day, second last panel of the day? Second to last. So I just thought we should just stand up for a sec. Yes, I have young children, but it's really hard to be in your shoes and doing this all day long. So I just thought we'd stand up for a sec and then we can sit down. But it's just nice to, a little stretch. I saw that, no, that's later, but actually it is somewhat of a good segue. We can sit down now. Thank you, everybody, to what I do for a living. I'm Abby Levy, and I run a venture fund, early stage investing in startups that focus on aging and our older population. And one of the things that is very real about aging is it's not really just about what happens to us when we hit a certain number, but aging starts obviously much younger. And so I was at a dinner party last night and running a fund focused on longevity. I always get asked the question, Abby, what's the secret? As if like there's some magic pill or potion and that you can take. And yes, there are some, new gene therapies and plasma this and, peptides that. But the reality is the majority of healthcare is behavioral. That is a big piece that we don't really talk about as much because it is the hardest piece to solve and to nail. And it's a lot easier in some ways to talk about pharmaceuticals and surgeries and other interventions. But I digress. I run a venture fund. I absolutely love what I do. We have about 35 companies in Fund 1. We're investing out of Fund 2. And our focus truly is anything that impacts an older adult. So happy to have this discussion because policy is a big piece of the tailwinds in our industry.
Thank you, Abby. Jeet, welcome.
Hi, good afternoon, everyone. Thank you, Rakesh. I'm also a lifelong learner, but I'm not nervous. The reason I'm not nervous because I have few friends in the audience. If I don't know the question, I can always ask Rasu or someone. They have the answers for me. So anyway, my name is Jeet Barmicha. I am an internist by training. I continue to practice medicine. And in part-time, I am a Chief Information and Digital Strategy Officer of our health system. As of January 1st, my role has changed a little bit. I don't have an official title, but I am doing more work with the same salary. So we'll figure it out. I work for an institution which I'm very proud of for last 28 years. This is 160 years old institution. It was the only institution in the country for chronic illness after London School of Tropical Diseases. We are very proud for the services we provide in the community, and we'll discuss a little bit more about how federal and state policy impacts the services we provide. All those of you who do not know, Bronx get a lot of accolade for the wrong reasons. We are the 62nd county in terms of health indicators. There are only 62 counties in New York State, so anything we do with the policy change, we can really move the needle. And I can talk about some of those policies which are in the pipeline. We are hoping that wellness and prevention will thrive in the county of Bronx.
Great, thanks, Jeet. And Tom, over to you.
Sure. Hi, everyone. Tom Castles. I am a managing director at Manat Health. So it's an integrated policy, legal, and business strategy consulting firm. I absolutely love it. We get to work very closely, and I'm from the Bronx, so love to see the investment that's being made there. I've spent 20 plus years as a healthcare consultant. The last 5 years, I ran an organization called Rock Health, where we both invested in early stage digital health companies at the nexus of patient experience and clinician experience of providing medicine, and then an advisory business for folks who are adopting those technologies. And I'm really excited. This is like, I'm really interested in longevity. I'm also very interested in um, uh, chronic disease. So I think we're going to have a really fun conversation.
Terrific. Thank you. And I realized I didn't introduce myself. So I'm a clinician by training, a GI surgeon, originally from England. That's where I was born and brought up. And I've kind of done a bunch of jobs, and probably most recently was at Jefferson Health in Philadelphia. I ran innovation and the venture arm of that health system. Got to know a lot of startups, loved it so much, gave up my clinical and academic practice, and now I'm fully in the startup world. So I have a startup that's just over 2 years old in the obesity and metabolic care space. So hopefully we'll talk a little bit about that. So now over to the panel. Many of you will know an entity called the Commonwealth Fund, which produces a report annually called Mirror Mirror. And they look at a bunch of countries, obviously the US, UK, Australia, and they rate them. And the US generally doesn't do very well, right? In terms of, we're at the wrong end of the scale in terms of cost and at the lower end of the scale in terms of outcomes. And that is obviously an amalgamation. And if we think about not just policy, but practice, I'd love each of the panel to share, some initiatives that either they've worked on or they've engaged in or just aware of that really can drive more prevention, value-based care, better outcomes at lower costs. And maybe we'll kind of mix it around. We'll start with you, Jeet, around how do we help our country rise up that rating of Mirror Mirror?
As I said, if I don't have the answer, I have few friends in the audience. But anyway, I'll take a shot. Let me talk about locally first, and then we'll talk about globally. I did read the report from Commonwealth, and but if you look at the access, I mean, I think US did a very good job in terms of access, which is unheard of in other countries, especially those who are on public programs. So yes, they're always good. There are always opportunity we can learn from these studies. Coming back to southern or the northern part of New York City, I mean, if you look at Manhattan and the Bronx, which is the northern part of those who are not from New York City, there's a Harlem River. So anything south of Harlem River, look at their longevity, and anything north of Harlem River to the Bronx, I mean, 62 in the state of New York. So what we are looking at, a lot of social needs or social care needs as it related to health. And New York State has been very fortunate, or very, I would say it advanced in comparison to other states, receiving 1115 waiver to create what we call it social care networks. And that was released last year. I think this is the first anniversary for $7 billion. But I think the objective of this particular waiver was to create social care network, which is very unique to identify, or not only from the patient's perspective or their social care needs, but also community-based organizations who can help between the four walls of the hospitals and the ambulatory care and everything in between. So we are very fortunate that 1115 waiver was received. And this is something very unique. As I said, I practice internal medicine, but not in the ambulatory care. But this is something new for even for our clinicians as well. The social care needs, whether it is food insecurity or housing or transportation, we used to document here and there, but now it is more structured. And with the help of the intermediary for us in the county of Bronx is Somos, who is one of, I think, 9 social care networks in New York State, to identify and connect the dots. I think these are all framework, these are all infrastructure, and this is part of District 2.0. District 1.0 was prior to COVID, where the goal was to reduce 25% of ED visits and preventable admissions. That was a 5-year program. Within 2 years, I think all of them, including us, we achieved that goal. So with that, I think this is the, I would say, stepping stone in terms of building the infrastructure, which is more focusing on prevention, which is more focusing on social needs for total health, or digital twins, what we call. So I think we are in the right direction, and we are very fortunate that I'm very proud of the institution where I am and the infrastructure we are receiving, so that we can not only take care of acute illness, but also get into the wellness phase of prevention.
Terrific way to kick off that question. Abby, if I can come to you, share some of your thoughts.
So I'm going to say a very obvious point. The head of strategy at a large health plan is an old friend of mine. And he said, listen, we know that there's a correlation between how the frequency of touch points we have with an individual and their health outcomes. I mean, it's such an obvious point, right? You know, it's just the more we get in front of them, the more we engage, the more information we learn, the more interested they are, the more we can preempt, we can prevent, we can take care of that. Social needs and social organizations, especially for older adults, has been the primary delivery mechanism of that. But if you think about any other industry, if you said in e-commerce, how do you get in front of your customer more? They're going to use technology. They're going to use text. They're going to use prompts. They're going to use, all these different means to get in front of someone more frequently. And healthcare has really been, both from a regulatory perspective, a fragmentation, no quarterback for care. There really hasn't been that push on engagement that leverages technology. And so when I think about outcomes, the companies we're looking at and investing in are showing and demonstrating, when we are engaging with individuals, patients, members, residents, and senior living case on a more frequent basis, we have better outcomes. That can be everything from, yes, doing your annual health wellness visits, which we know is really important, particularly for seniors, to have those annual visits. So simple. Like, wouldn't every person want to go have their annual visit? There's a gazillion reasons why that's really hard. Issues on medication compliance. Well, I have arthritis. I can't open the pill bottles. Well, we didn't know that. So all of these things are solvable now. A lot of them are solvable through tech-enabled care coordination and having this sense of looking at a holistic person of someone and engagement. So I think that's just kind of a meta point when I think about the types of things we're seeing around outcomes. One is engagement. The second theme is kind of tied to engagement, which is the consumerization of health. We talk about the study that you mentioned from Commonwealth. Healthcare has an NPS, Net Promoter Score, basically popularity score of like 20%. So consumers are starting to basically vote with their feet to not engage with the health system. Affluent people are doing it through concierge medicine, and the rest of the country is just not doing it. They're not engaging. And so how do we think about other entities and organizations where healthcare can be delivered, whether that's through the senior center, whether that's through family caregivers and family members? We're basically building up a shadow healthcare system. Think about yourselves when, yes, the last call we make often is to go to the hospital or the doctor. We try to use Dr. Google in every other way possible. Sorry, we're at Microsoft Office, but, Bing, to be able.
What's Bing?
Yeah. So, I think another thing we're seeing in a lot of the companies that are starting off is giving consumer choice and giving consumer access to care in ways that can have them unfortunately or fortunately circumvent traditional brick and mortar hospital, because that is just a real challenge to navigate.
So going to chronic disease management, focusing on engagement. Tom, your thoughts?
Yeah, one of the things I think would be really interesting would be to isolate other countries that are as diverse as the United States, because one thing that is very different is we have an incredibly diverse population, but not a diverse system of sick care. And we actually don't have a system where we finance health. So, a lot of the preventive services that are more accessible in other countries, they're not particularly accessible, and that's a real issue. I think we wait and wait until people are very sick, and then we have way higher prices. That's the answer. Prices and an unhealthy population to start with. So what do you do about that? A lot of what we've already heard. But I think the most important thing is to start with children and give them agency in their own health, prevention, education, etc. It is very difficult to hold to account people who have all the resources in the world and people who have none, and think you're going to even it out and have an average health set of health outcomes.
So Tom, I'm going to take your comment, and it's very well put, around going from sick care to healthcare. In the country where I grew up, the National Health Service used to, flippantly call it the National Sickness Service, because the NHS waits till you get sick and then treats you. There was an election in the UK a few months ago, and a new government came in, and a report was written around the state of the National Health Service, and it's in a critical condition. It's on its knees. And my question is going to be about scaling innovation. And just to give you a bit of context, there's 7.6 million people in a country of 60 million people in the UK who are on a waiting list for elective care. Whether that's a hip replacement, a cataract surgery, a hernia repair, or so forth. Some of these people are waiting over 2 years. So I agree with you, Jeet, that it's not a perfect league table from the Commonwealth Fund. And the National Health Service has said we're going to do three things. It's already been mentioned, we're going to move from hospital to community, we're going to move from analog to digital, and we're going to move from sickness to prevention. I don't think anyone would disagree with any of that, and I think we've already heard it. So I come to a lot of these conferences, and it's great to see the panels, and with the startups. I have a startup of my own, but the challenge I see is, how do you scale that? How do you scale that across a population, across a state, across beneficiaries? And so that's really where my question is going to go. I'm going to start with you, Abby, around when you look at startups, and you've been at a bunch of startups that have scaled pretty tremendously. Like, what are those? I don't want to say key ingredients, because it sounds like there's a magical potion. But what's the grit that's required to get that scale within healthcare and go from innovation to just standard practice?
It's been disappointing to me over the past 5 years since I've been running my fund, that commercial velocity. So as a startup, as an investor, you talk about product market fit. Is there product market fit? There are 10x the number of companies with great products than there is commercial demand for. It's never an issue of, is it a great product? Does it work? And, can it help somebody? The issue is you have to go through commercial pipes, and those pipes are clogged, period. And so where we found the most commercial velocity is where the pain is the highest, where it's hospital systems that are getting dinged for readmission rates for 30 days, and they're going to need to put in place some hospital home care coordination, something for those 30 days to make sure that they don't get dinged. It's where the money is. You know, the number of Medicare Advantage plans that once they started, their star ratings got dinged for health equity, which by the way, let's not even talk about that.
Yeah.
Sorry, I'm just a little traumatized this week. But that is something that everyone, again, fire was burning, money was going out the door. Let's solve health equity. So we have a system that understandably, because it's privatized, is focused on profits. And that's how we design the system. We're one of the only countries in the world where that's the case. And if you have to look at, you have to say, that barbell of quality and cost, what's the thing that makes the US different? Most of healthcare is privatized. And so, but that is the system we work within. So to answer your question, what we've seen, commercial velocity is where's their immediate savings, period. That is on the commercial side. There is a secondary commercial avenue that is around this question of on prevention that is ultimately around pharmaceuticals. That has been the literally, and GLP-1s is a perfect example. On the list of drugs, I'm excited, on the list of drugs that should be evaluated for Medicare to negotiate prices for, GLP-1s is the number one in the second tranche. And since they've launched, there's been 2.8 million older adults on GLP-1s. So glad that that is an option to them. But that is where we as a society have said that is the way we're going to handle prevention, is through medication. So, I sound very Debbie Downer on this. I think the companies that are doing this really well and are growing really fast are recognizing that the way in is through the commercial path of helping to fight some of these fires, keeping older adults out of the hospital, helping with medication reconciliation, fall prevention, all of the big buckets of cost is where you have to start.
Thanks, Abby. I'm going to go to you, Tom, next, if I may. Oh,
Tom.
sorry.
No, Tom.
Yeah.
I don't want you to take a detour. Go ahead.
So I think two things that I think would increase the cycle time of innovation. One is having as a norm, clinician innovators and clinicians on the product teams of companies who are trying to drive change. It is shocking the number of times I have talked to product teams at startups. I also work at an investment fund, and I ask a simple question. I was like, how much time did you spend if you're selling to a hospital, in the hospital actually watching the end user for your products? And the answer is usually none. That's not a great way to get adoption. The second thing is, and this, well, yeah, I'm just going to say it. I do not think that the CEOs in healthcare show much backbone in terms of supporting innovators. Conserving what we have is what most payer CEOs, most provider CEOs, and frankly, most life sciences CEOs do. However, in the rare occasion where you have a CEO who really gets behind having more than an innovation department, but actually investing in things that we don't do now, that are good for health, that I think speeds things up precipitously. And you know, I think I'd like to see a leadership kind of paradigm of more risk taking among healthcare CEOs, because only then will their teams feel supported to take the risks that that I think innovation requires.
I couldn't agree more with you, Tom, and we can talk more about that shortly. I'm going to go to Jeet, but then we're going to open this out to the audience rather than do it right at the end, and then we'll come back to the panel. So if you've got any comments, thoughts, and even stories around this area, please pop your hand up in a moment. But Jeet, let's talk about scaling innovation.
I'm not too sure whether you call this innovation, but when our health system or hospital was built, in 1866, it was called Home for the Incurables, and that was the only in the country actually for leprosy and syphilis. Patients were sent to die there. But over the years, obviously, academic programs, med school, and it has become an acute care hospital. 4 years ago, we went into wellness space, and I think, to my knowledge, I think it was the only unique strategy or our mission came up with to ask a developer. We donated our land. They created a 350 low-cost housing units. That is number one. Number two, we created a 50,000 square feet of wellness space where we have teaching kitchen. We have a gym, and there are other classes also in the gym. And then we have rooftop gardens where the produce comes and either it's given to our community members or goes to our kitchen. Again, it's a very small way to contribute, and the optics of having that St. Barnabas Hospital or SBH health system is not only for the sick people, but we are also investing these things in the wellness. So if you were asking about the ingredients, I think this is very unique. Once you get into value-based care, once you get into prevention and wellness, and imagine all the academic medical centers or health system across the country get into this space, including FQHCs or others, in a very small way. I don't expect everybody will have a rooftop gardens but anyway, if you can collaborate with CBOs, I think that will create an infrastructure that hospitals should be for ICU care or ED care, and rest everything can be done in the community care. So I think that would be one. And second, which we have invested in last 5 years, is in behavioral health. We make sure that our mission is aligned with behavioral health needs. Whether we do primary care, whether we do acute care, back, front, up, north, south, everywhere is behavioral health. So these two investment in last 5 years are just the stepping stones. And we hope that in 10, 15, 20 years, we'll see very good results actually.
Perfect.
So I feel like I was Debbie Downer. The counterbalance to that, and I can't believe we've been on a panel in healthcare for 15 minutes and no one has said the two letters AI. And so the reason I bring up AI is when you think about when I talk about commercial velocity, in the past 6 months from the enterprise customer, we have seen serious FOMO, fear of missing out. We have seen CEOs say, what is my AI strategy? And we've seen a broad acceptance, I think, that AI can be used in healthcare. I think there was such mistrust, honestly, even up until 2024. I don't know about you guys, but there has been a change. Maybe as all our kids are using ChatGPT to write their papers, and we've just all started using it on the consumer side, that it has opened up this understanding that actually healthcare is the optimal use case of AI because we need to start delivering personalized care. personalized care is going to come because we have more data based on your blood biomarkers, on your genomics, on all of these things, and that we can look historically or going forward, start to track which medications for which blood type did this. Like we're going to have such richer data that can deliver personalized medicine, precision care, whatever you want to call it. So we are seeing velocity of healthcare institutions starting small. They're saying, how can I use AI? I can solve it for my number one pain point, which is staffing. I can solve it for workforce automation, for care plans, for staffing coordination, all of that. I can use AI. That's safe. It's not patient. I mean, it's not used as recommendation for patient care, but it's a safe place to start. That is the tip of the iceberg. And so we feel very optimistic that there will be more openness in channels because of this almost leapfrog technology. It's like healthcare institutions just skip the past 10, 15, 20 years of tech and are just going to leapfrog ahead with the only barrier we see is Epic.
I think that's a great point. I was actually going to ask about AI in my next question, but it's a great moment to open this out to the audience. So any comments? Yes, please just say who you are and then please ask your.
So a couple things that I think that I'm kind of putting together from the beginning this morning's conversations to now. I think first of all, I agree with your Epic comment. I think it is they've created the walled garden of mediocrity, and they have built that moat around that to prevent innovation. But that said, I will also say that I worry that we work on things without fixing the stuff that people are crying out for. How many people think their My Chart is an awesome experience and helps them access and manage their care? Right. How many of the clinicians in this room say, I can't wait to chart because it tells me so much information and helps me provide great care to the patient in the room with me. I think we've got in healthcare to admit we still have to fix some foundational items to get to all this other stuff. And I worry that these groups that we're pouring all this money into really good ideas, but we're not ready as a health industry for them. We're just not ready for them. And that's the kind of stuff that I worry about every day. Nobody in the New Jersey markets that I are serving are saying, I wish I could, and doing some of these things. They're saying, I can't get an appointment for 6 months. That's what they're telling us.
Thanks, Pam.
And
yeah, please, Tom.
hi, Pam. It's been years. I think one of the things that I don't want to miss from the last couple of comments, and yours blows it out of the water, is when we talk about innovation, I think we have to think about how we use technology, people, and processes to do things better and to do better things. Sometimes we're just like jumping, like, let's just do better things, without like actually looking at, would it be more effective to use, just going to use a vendor, not a client, be well connected, to give a chance for us to give a patient their health records. And we know they have probably 5 other portals, 6 different Epic portals, and actually put all of that information together. Like, that is doing something better. We're doing, and I do think that we don't a lot of investment dollars go toward, we're going to just do better things, like skip the part where we fix what hurts the most.
We have operational issues that we have to address. And we have revenue cycle issues we have to address first to be able to accept some of the innovation layer on the top of it. So I think that from my perspective is every time I meet with a company, I keep thinking, oh, I've got to fix my operations at the back end to be able to handle this work. There are new workflows that are going to come in, and I've got to do a lot of change management around that to make it work.
Yeah, it makes me think of a paper I read many years ago about the ambidextrous organization. I think it was in Harvard Business Review, which is, you got to run the soldiers, but then you've also got to have the artists that are bringing in the new stuff. And how do you do that? And over coffee or something, I can talk about some of my experiences when we were running innovation at Jefferson on that. I want to get back to your point, Abby, around AI. And I'm pretty amazed. But first of all, I agree with you. AI for healthcare, yes, absolutely. But it's like, where do we start? How do we go forward? And I was actually talking to Meg from the Peterson Institute over lunch today about, like, you're doing these reports, and you kind of, a digital diabetes solution probably doesn't change that much over a year or two, right? But the AI solution, just the way it works, and then you've got quantum computing coming in as well. These things can change, maybe even over minutes. So how do you deploy the governance over these AI solutions that are being adopted? You mentioned some way of like maybe staggering how you start. Tom, maybe you want to kick that off around how do we know we're doing this right? First, do no harm, basically.
Well, one way that we're not doing harm is that most of these application layers don't work. So people aren't using them. What I think we're doing right, a company came out of stealth last week called Qualified Health that isn't building applications. They are building infrastructure, governance, and monitoring. That, to me, and I'm an odd person, I was like, that's a sexy business. And, I think we have to love those kinds of businesses in order to actually get to the point where we can tell what the impact of using some of the application layer looks like. And without that, the trust just isn't there on the front lines.
Abby, you're nodding.
But have a quick add in this kind of, unfortunately, I actually think that most of these things are going to be proven out outside hospital systems. So there's a reason most of our companies sell first to small regional payers, not the big ones. They sell to ACOs because they have a better holistic picture, to PACE, also a holistic picture. They already are aggregating a lot of the data. They're just not doing anything with it. They're not doing enough with it. And so I think the applications of AI that are working are where you have an organization that has a much simpler operating system, potentially newer, and they already have multiple touch points with the end user, and it's not as fragmented. And so I do think that's the case. I will again say something like staffing and revenue cycle management are two applications that hospital systems are deploying AI quite, because they're not as integrated in Epic's walled garden. I mean, they can kind of sit at the periphery. So we see innovation starting in other channels other than hospital systems in terms of uptake. It would be great if that wasn't the case, but it is.
And G, your thoughts around
Yeah,
governance?
so I'll take a little bit different approach. Most of us know AI is nothing new. It's been almost 50 years old. What is new is the generative AI. So I think we need to differentiate between the traditional AI or generative AI and the future of generative AI in various categories. As far as we are concerned at our health system, or what I feel, definitely there is a role. This is a natural progression of data innovation. I mean, generative AI is nothing but data innovation. 20 years ago, many of our health system did not have EHRs. So if you look at 20 years or 25 years, we have collected so much data. So and then people who are data scientists or statistician, now we have better understanding of these LLMs or other models, what we can do to the data. So this is a natural progression. And in terms of clinical intervention, I mean, I am a physician. I see patients when I'm in front of the EHR. Yes, anything outside of clinical interventions, there are some very good use cases, whether it is ambient or administrative or patient engagement, other solutions. It can really, really speed it up and make us more efficient. But when it comes to clinical intervention, or somebody is using generative AI on me, I want to make sure that it is not biased. These algorithms are not based on certain race and ethnicity and trying out on me. I'm from India, so it better work. So I want to make sure it's ethical, it is responsible, it is trustworthy. Otherwise, any clinical intervention will take some time. It's like medications. I mean, Tylenol, if you know, it had phase 1, phase 2, phase 3 trials, but again, we don't need to go for a few years. Maybe within a month or two, we can do these, have some evidence based in terms of clinical interventions. But for non-clinical interventions, as Abby mentioned, yes, definitely we can speed it up. Healthcare is a little bit behind. Other industry are already doing it, especially service industries. So yeah, it will be an enabler, but you will still need people like me who can see patients. I don't want any robots to come and examine you guys.
So we're sadly going to have to wrap up in a few minutes. I've got one kind of quick shot question for each of the panel. I'm sure the panel will be around if you have other questions for them. So my quick shot is really going back to the top of the session around, mirror, Commonwealth Fund. If we look at cost, quality, access, equity, patient experience, it'll probably not be lost on you that there's a new administration in this country. And so I'd like to ask each of the panel if they had one area of healthcare that they would like to improve over the next few months to years. What would their thing be? Let's start with you, Jeet.
I think it's only 2 days old, or I'm still reviewing the executive orders, so I'm not too sure. I just hope that the infrastructure we have in place, whether they are electronic health record or care processes, where technology is an enabler, continue to move in the right direction, or maybe a little bit faster, and so that we don't go back on paper, we don't go back on traditional. But I'm sure the tech leaders who were surrounded at the inauguration ceremony will make sure that technology or AI will just be an enabler to keep us healthy.
Thank you. Abby?
I had a prepared answer around home care because it's very germane to what I do. I think one of the things that we've seen is that regulations are changing corporate behavior. And the question is, how could regulations change individual behavior? The Secure Act 2.0, which forced small employers to offer 401ks. And now there's new regulations saying that when those are offered, they're not going to be opt-in. You're going to be automatically enrolled in a 401k, because data has shown that that is the way 50% of Americans don't have enough money to retire. And when we went from pension to 401ks, we don't have enough enrollment. And so it is regulation that is basically forcing behavior change. And I hate to say it, but I think the same thing is true in wellness and preventative care. If you couldn't receive your paycheck unless you got an annual wellness visit, if you couldn't get your Social Security check unless you had an annual wellness visit. We would have annual wellness visit. Everyone would be doing annual wellness visits. And so if I had a magic wand, it would be for the anti-regulatory administration to think about healthcare regulations and see where there is the opportunity to incentivize folks. We used to think that the incentive would be living well, but that is not enough. And again, I sound very dark and sarcastic and all of these things, but I actually think that regulations are positive in health, can be a positive in healthcare if it's focused on the individual in the right way. So I think that would be kind of interesting to figure out how annual wellness visits become mandatory.
And Tom, take us home.
I think from, the Puget Sound to the Gulf of America, we lack we lack a seriousness about access to primary care, and by that I mean pediatrics, geriatrics, family medicine. I do think that there is, and I'm optimistic about this, that the incoming administration would like to change the nature of reimbursement. That won't make all doctors happy, but nothing will make all doctors happy. So, if there was one thing that I could do that wasn't cynical, it would be to support the administration in moving toward greater primary care parity.
And one quick add to that is that if all healthcare training and certification was free, I think that would remove a barrier for the care shortage that we have. And I know we talk about wages and compensation. I think that's going to be a lot harder to solve from an ongoing perspective. But one of the things that's been really cool with the startups is that they're really figuring out how we use every possible care worker, from community health workers to medical assistants. Like, there's a lot of companies that are enabling folks that aren't MDs to practice the top of their license. In 28 states, RNs are allowed to practice like MDs in a lot of ways. Like, we need, in order to fulfill that dream of everyone having access to care, we need more care providers. And so that to me does seem like a relatively low bar. And I wish the Gates Foundation and all these folks that are spending a lot of money on global health would just fund domestic care worker training and certification and upskilling. So if you can do that, that would be awesome.
Well, thank you. And I appreciate Megan and Shahid. It's not like the Oscars where the music's getting louder and louder and we have to get off stage. Please put your hands together to thank Abby, Keith, and Fred.